close.
Yes,
Is it okay?
yes, yes. Yes.
So, before going into the proper, let me just narrate a story which happens to be a clinical mystery, which was found in 1980s in the Cornell Medical Center, which is in US. So, despite giving the normal dose of digoxin, the patient was labeled unresponsive. Can any one of you tell what could be the reason? So, since it's an online session, I'm not expecting an answer, but you could try writing in the chat box. So, as most of you might be knowing, digoxin was converted to dihydrodigoxin by Egertella lenta. So, Egertella lenta is a commensal in about 10% of the patients, and these 10% of the patients were non-responders. And the scientists at that time, when they incubated the digoxin with the stool of the patient, they found that the principal drug, that is digoxin, was nowhere to be seen. So this led to the thinking that digoxin could be metabolized by the microbiomes. That is in the 1980s. So coming to the topic proper, for the next 25 minutes, we'll be talking about pharmacomicrobiomics, harnessing the therapeutic potential of the microbiome. And I'm Dr. Danya. I have not deliberately kept the name in the slides because all these slides have been generated using Google Notebook LM, and not all the slides, majority, maybe 98% of the slides, I have used Google Notebook LM for generating the slides, but the material I have identified and confirmed the genuinity of the resources. So, coming to the history of uh, pharmacomicrobiomics, it's in the 1880s that the suspicion that there could be organisms in the gut which could lead to putrefaction and influence the systemic health. And in 1930, which drug was discovered by Domac? It is Prontosil, and in 1930, Prontosil was discovered. And what did they notice? There was a paradox. They found that Prontosil was effective in vivo, but it was ineffective in vitro. And the paradox was that Prontosil was a prodrug which was activated to what? A metabolite, which is like PABA, and that was with the help of azo reductase. So in 1930s itself, the microbes were involved in the conversion of the drugs. And in 1940s, the drug we commonly used for the treatment of inflammatory bowel disease, that is sulfasalazine, was found to be needing azo reductases, that is released by the microorganisms. And in 1980s, the digoxin anomaly, that is the identification of Egertella lenta, which inactivated the heart medication in 10% of the patient. And even now, when we are trying to find out more of research that is related to pharmacomicrobiomics, now the current situation is that this is precision metagenomics, and specifically the immune oncology relies on specific microbiological taxa profiles as prerequisites for checkpoint inhibitor efficacy. But it is in 2010 that the term pharmacomicrobiology was coined. So, who coined the term pharmacomicrobiomics? So actually, she is now a PhD scholar and as a computer engineer, Mariam Riyad Rizqallah, along with her colleagues and her guide, maybe Rami Karam Aziz, who coined the term pharmacomicrobiomics. So that was way back in 2010, and they define pharmacomicrobiomics as the effect of microbiome variations on drug disposition, action, and toxicity. So it was published in the journal Current Pharmacogenomics and Personalized Medicine. And at that time, she said that there should be this website, that is the pharmacomicrobiomics.com. So this is a website where we can see about database. We can browse the database, the publications related to it, and the literature feed, everything related to pharmacomicrobiomics. So now am I back in the slideshow screen?
Yes, ma'am. Yes.
So now the question arises, when 99.9% of the human genomes are identical and the clinical indication is identical, why doesn't identical drug or identical dose work for all the persons? Some persons could be cured, some persons could have no response, and some could have a toxic reaction. Now, the variable for the clinical uncertainty, we have studied lots of variables which influence the drug action, from age, gender, height, weight, concomitant drugs. Then last year I was talking about pharmacogenomics, and everything could be related to the responder, non-responder, or the adverse reactor. So till a few years back, I was thinking that only the genomes were actually associated with this responder on non-responder status. But now when I read more, I understand that it is the microbiome which is also influencing this. So what is the classical algorithm for pharmacokinetics? That is the host genetics along with the age and environment. This is actually managing the classical pharmacokinetic algorithm. And when we studied from undergraduate days, we study liver as the solitary engine of drug metabolism. Of course, we study the intestine, the lungs, the skin. But now there is a hype over the forgotten organ, that is the hidden liver. And the modern pharmacokinetic algorithm says that the classical factors is severely influenced by the hidden liver, and that is the gut microbiome. So how does the two metabolic engines vary? What is the difference between the liver and the lumen metabolic engine? So we know that the phase 1 and phase 2 reactions occur in the liver, and that is mainly with the help of the CYP450 enzymes or the UGTs or the sulfotransferases. And the ultimate aim of these phase 1 and phase 2 biotransformation reaction is to render an active drug inactive, render a lipophilic drug hydrophilic, so that it can be detoxified and removed from the body. But the microbe doesn't always work like that. We have reductive and hydrolytic primary pathways, and the key enzymes are azoreductases, glucuradases, and decarboxylases. And here, the biochemical goal is a facilitation of the anaerobic respiration. And here, actually, lipophilicity is increased, and it can even reverse the phase 2 metabolism and reactivate the toxic compounds or create novel metabolites. So when I started talking about the human genome, I told that 99.9% of the human genome is identical from one person to another. It is in 2007 that the Human Genome Project started. Now there is a huge research going on the second genome. Can any one of you identify this original? Who is the painter of this original figure, or what is this figure? Actually, this is a picture of Da Vinci. This is the Vitruvian Man, and now it has been uh, given a newer outlook. This is the same man at different point of time, and we can see that at the same point of time, his organisms will be different. That is, even a single person can have different microbiomes at different point of time, and the variation from one person to another can be up to 80 percentage. That is, the identical percentage of microbiomes will be only up to 10 to 20 percentage, even in identical twins. So the microbiome cloud is usually going alteration that could be due to environmental stresses, dietary inputs, time, place. Everything can cause a change in the uh, microbiome cloud. So, with this introduction, once again reinforcing pharmacomicrobiomics, it is the microbiome effect on drug absorption, activity, and toxicity. At the same time, what is pharmacoecology? That is, the microbiome changes as a result of drug absorption, drug administration. That what the drug is doing to the microbiome is a pharmacoecology, and toxicomicrobiomics is the variations in the microbiome that affect the toxicity of xenobiotics and drugs, and pharmacoinfection is the effect of pathogens on drugs, pharmacokinetics, and pharmacodynamics. So as I told, the type 1, that is interaction is between the microbe and the drug. Mainly it is the pharmacokinetic interactions like absorption, distribution, metabolism, and excretion. And one important example is the levodopa degradation by Enterococcus fecalis before it reaches the brain. And the pharmacoecology, that is, even non-antibiotic xenobiotics can shift the diversity and function of the gut community. And one classical example is metformin, increasing the abundance of Akkermansia muciniphila. Does anyone know what is the role of Akkermansia muciniphila? Actually, it is a normal commensal in the intestine. And in the intestine, it is sitting and eating the intestinal mucosa so as to keep it healthy. So, the abundance of Akkermansia muciniphila is noted to have some effect in the metformin antidiabetic effect. So, other drugs other than metformin that the drugs altering the bugs are, we all know excess antibiotic usage causes dysbiosis. Similarly, proton pump inhibitors, steroids, and antineoplastics all reduce the diversity and pathogenic overgrowth. Actually, when 1,000 drugs were screened, 24 percentage of these human targeted drugs showed bactericidal capabilities against representative gut strains. So when we are talking about antimicrobial stewardship, we should be also cautious about use of drugs like proton pump inhibitors, steroids, and antineoplastics. So coming to the examples which you are very knowledgeable about, or which you need to write for your exams because it is there in our Goodman and Gilman, the bugs altering the drugs. It could be direct activation, direct inactivation, direct toxicity, and even the physiological impact. It can be bidirectional. Heavily, it flows both in both directions, completely altering the patient outcome. So, what happens to a drug when it encounters a microbial enzyme hub? What happens when a drug encounters our enzymes, the host enzymes? That itself happens when it encounters the microbial enzyme hub in type 1 type of reactions. That is, either a prodrug can become inactivated, it can become activated, activation of a prodrug, or an active drug can become an inactive metabolite, or this doesn't happen usually in our body, except in the case of it doesn't usually happen. That is toxification. That is phase 2 metabolite rendered devoid of glucuronidase, so that it becomes toxic. So enterohepatic cycling, that loop is encountered by the bacteria, and that can lead to toxification. So as I already told, it was in 1930s that the Prontosil paradox happened, and even though the in vivo efficacy for Streptococcus was very high, it was the in vitro action was not seen, and then Domack found that it was because of the gut bacteria, which was reductases, which converted Prontosil to PABA, and he received the Nobel Prize in 1939. Now coming to the classical example, sulfasalazine. For which other disease sulfasalazine is used other than inflammatory bowel disease? So other than for inflammatory bowel disease, it is used for rheumatoid arthritis. And in inflammatory bowel disease, is it the sulfapyridine moiety or the 5-ASA moiety that is active? I cannot see any response. I hope at least in your mind you are responding. So
ma'am, they're answering, ma'am. 5-ASA, they're answering. 5-ASA.
Okay. Okay. I can't see the chat. That's why I'm keeping on talking. So it is the 5-ASA which is active in inflammatory bowel disease or ulcerative colitis, and in the rheumatoid arthritis, it is the sulfapyridine. So we need which enzyme here? We need the azoreductases enzyme, and this azoreductase will convert. Actually, here the role of sulfapyridine is just to avoid its metabolism in the upper GIT, so that it reaches the lower GIT and it releases mesalazine or 5-ASA, which is effective for ulcerative colitis. So let's see the first case. So an ulcerative colitis patient is prescribed for sulfasalazine, and there is zero clinical improvement after 3 weeks. So the high levels of parent drug in stool, and there is no active 5-ASA detected. Can you tell one reason why this could happen? That is, there is no 5-ASA. Usually this happens when there is severe antibiotic induced dysbiosis. So the microbial key is missing. So sulfasalazine is broken down by microbial azoreductase to 5-ASA, and it is 5-ASA that is active. Now another enzyme in the microbiome, that is the bacterial arylamine N-acetyl transferase. The bacterial arylamine N-acetyl transferase can inactivate 5-ASA as well. So these are the two reasons why sulfasalazine could be not effective in a patient. One could be because of the antibiotic-induced dysbiosis, which is decreasing the microbes, which is producing azoreductases, or another reason could be because of the acetylation of 5-ASA, bacterial arylamine N-acetyl transferase. So the usual chemical process that are happening are reduction, acetylation, dealkylation, demethylation, hydrolysis, beta-glucuronidation, and deamination. And another example that you can correlate with the activation here, the bacteroid species, they will hydrolyze the lactone ring. So the bacteroid species is involved in hydrolyzing the lactone ring of lovastatin. Lovastatin is a statin, and it is a prodrug. It is converted to an acid. So that hydrolysis is by bacteroid species. Again, when a patient is having antibiotic-induced dysbiosis, the microbiome gets depleted and the levels of lovastatin falls down. Another classical example is our Agathala lenta. So at the start of the session itself, I told it is a very important example. Even though when I was studying my MBBS time or the postgraduate time, we were told that digoxin use is getting less. Still in our institution, digoxin is being used. Digoxin is still used, and the digoxin the interaction with microbiome is still relevant because 10% of the patients have this Agathala lenta. So in a Goodman and Gilman, DMS 2243, it is written like that. Actually, it is DSM 2243. So Agathala lenta, the specific strain DSM 2243, it switches on the operon CGR operon. What is CGR operon? That is cardiac glycoside reductase operon. And what will happen? Digoxin will be converted to inactive dihydrodigoxin, and the efficacy of digoxin will decrease. So what will happen if we give a high dietary arginine to this patient? So when high dietary arginine is given, it will switch off the cardiac glycoside reductase operon, and that will help in rescuing digoxin. So digoxin will become effective. So here itself we can see how food, microbiome, everything is interacting, how it is multifactorial. The effect of drug is multifactorial. Now, in the initial slide, what I did not tell was that at that time the scientists found out that it is dihydrodigoxin. The stool, when digoxin was incubated with the stool, dihydrodigoxin was formed and digoxin disappeared. And when the patients were given erythromycin, the effect of digoxin reappeared. So what could have happened? Erythromycin would have killed all the commensal Agarthala lenta. Similarly, when we give broad spectrum antibiotic like tetracycline, what could happen? It will also kill the commensal Agarthala lenta, and the digoxin efficacy will return. Another classical example is of tacrolimus. So tacrolimus, we all know, is an immunosuppressive agent, and it has so many other factors that is influencing. It is a narrow therapeutic index drug, concomitant drugs, or the CYP3, 3A5 enzyme, or even the use of food, everything can affect, even the disease status can affect tacrolimus. Now here is a bacteria, Faecalibacterium prausensii. So that's also given in our textbook. Faecalibacterium prausensii is a gut microbiome, and tacrolimus is converted to its M1 metabolite by C9 keto reduction. So tacrolimus is converted to M1 metabolite, which is 15 times less immunosuppressive. So what will happen? Tacrolimus efficacy will decline when this bacteria is present. That this gut microbiome, Faecalibacterium prausensii, will convert tacrolimus to the M1 metabolite, which has a decreased immunosuppressive efficacy. Now, coming to another mechanism, Faecalibacterium prausensii also increases the short chain fatty acid butyrate, and this will act as a histone deacetylase inhibitor, and it will cause expression of P glycoprotein. More expression of P glycoprotein, we all know what happens. P glycoprotein will cause efflux of tacrolimus. Again, what will happen? There will be a decline in the tacrolimus levels. So microbiome as a dosing marker is being researched in the case of tacrolimus. So high Faecalibacterium prausensii, we need high tacrolimus dose. Now what happens if this tacrolimus patient is given on a broad spectrum, or is started on a broad spectrum antibiotic? So as I already told, broad spectrum antibiotics will kill all the commensal bacteria, and what will happen? When this patient was optimized on high dose tacrolimus. For getting efficacy, his dose was escalated. But now what happens? Because of the use of broad spectrum bacteria, what happens? Suddenly, the tacrolimus range goes up and high toxicity can occur. So these are the examples of direct activation. So now coming to the indirect mechanisms, as I already told, one is the expression of the transporters. It can be the P glycoprotein, the organic anion transporters, or the cation transporters, any transporters, intestinal influx transporters can be up or down regulated, drastically altering the exact amount of drug allowed into the systemic circulation. Another key thing is the turning down of a phase 1 or 2 liver enzymes. So the classical example given in our textbook is paracetamol. So we all know paracetamol. Paracetamol or acetaminophen is usually metabolized by glucuronidation, sulfation and glucuronidation. Now what happens when the endogenous metabolite from Clostridium, that is the microbial metabolite P-cresol. Microbial metabolites like P-cresol are structurally identical to paracetamol. So what will happen? They will compete for the sulfotransferases and the glucuradases. And what will happen? When there is a competition for the sulfotransferases or the glucuronidase enzymes, what will happen? Paracetamol will go for forced oxidation. And what is the toxic metabolite of paracetamol? Paracetamol, CYP2E1, and forced oxidation, what will happen? It will, the toxic metabolite NAPQI is formed, and then the patient will develop hepatotoxicity. So even a very commonly used drug, which is very widely used by all the general population, paracetamol, it is affected by our gut microbiome, and it can lead to dramatic increase in the risk of severe hepatotoxicity. So coming to the next case scenario. So a patient who has Parkinsonism. So in the initial slides, I have told about the levodopa's conversion. That is Parkinson's disease. A patient is on standard levodopa and carbidopa therapy. But even after treatment, the efficacy is severely waning, and the patient is presenting with comorbid Helicobacter pylori infection, and there is also small intestinal bacteria overgrowth. Can anyone remember which was the bacteria or the microbiome associated with this? We have seen earlier in a slide, and the culprit is Enterococcus fecalis. Now, actually, it is a pre-systemic interference at the level of absorption. What is happening here? The Enterococcus fecalis is also having microbial decarboxylase. So it is slightly different from the decarboxylase of us or the host decarboxylase. So let's see, levodopa and carbidopa, it will safely cross the blood-brain barrier, and because levodopa is less converted, because carbidopa is protecting against the dopa decarboxylase enzyme. Now what happens? Enterococcus fecalis has tyrosine decarboxylase, and tyrosine decarboxylase will convert levodopa to dopamine. So can dopamine cross the blood-brain barrier? No, it is not able to cross the blood-brain barrier because Enterococcus fecalis, carbidopa does not inhibit the bacterial enzymes. Up to 56% of the levodopa fail to reach the brain in presence of Enterococcus fecalis. And also our Agartala lenta, it is converting the dopamine to M-tyramine. So now the the research has been going on a small molecule, that is alpha fluoromethyl tyrosine, has been synthesized to selectively block the tyrosine decarboxylase without harming the microbe itself. So it can reduce the L-dopa not reduce, it can rescue the L-DOPA bioavailability. So alpha fluoromethyl tyrosine, it is a small molecule that will specifically target the tyrosine decarboxylase of Enterococcus faecalis without affecting the host. So coming to the third case scenario, this is also very important. And irinotecan. Irinotecan, we know it is used for colorectal cancer. So here is a 42-year-old female with metastatic colorectal cancer. And we know that irinotecan is a pro-drug and it is converted to what is the active drug? SN38. Okay, SN38 and it undergoes glucuronidation by UGT1A1. Now here specifically it is given genetic testing for UGT1A1 star 28 is negative. Why? Because it is the normal metabolizer. There can be poor metabolizers associated with UGT1A1. Despite not having any poor metabolizer of UGT1A1, why does the patient develop grade 4 diarrhea? What is the other toxicity of irinotecan? Diarrhea and neutropenia. It can cause severe neutropenia. So why is this patient developing this? This is because of the opportunistic taxa expressing the beta glucuronidase enzyme, the E. coli or the bacteroids, they can express the beta glucuronidase enzyme. So here what is happening, hijacking of the enterohepatic cycling is occurring. So we know irinotecan is converted to SN38, which is 1000 times more potent than irinotecan, and this SN38 is inactivated by glucuronidation to SN38 glucuronidase, and it goes for biliary secretion. And what happens there in the gut environment from the E. coli and the bacteroids, the bacterial beta glucuronidase will clip off the protective glucuronide. So what is left? SN38 is left, and we know SN38 is toxic, and it causes severe mucosal damage and grade 4 diarrhea. So other examples of toxicities are metronidazole, a very common drug which could undergo microbiome processing and could be converted to the carcinogenic metabolite, or chloramphenicol, which is again chloramphenicol, which is widely used. It's aplastic anemia, could be associated with the myelotoxic metabolite formed after microbial processing. So another example is the NSAIDs. The NSAIDs also undergo enterohepatic cycling, and what happens, its glucuronidation can be again cleaved off by the microbiomes, and this can result in severe gastrointestinal toxicity and mucosal damage. So coming to the last part here, that is the immune checkpoint inhibitors. So earlier Ramya ma'am was talking about the PDL1 inhibitor, which was the PDL1 inhibitor. Ma'am told, she had told so many names. So the immune checkpoint inhibitors and the microbiome interaction has been found to be very upcoming area in the research circle. And the immune checkpoint inhibitors, the anti-PD1 or the anti-CLA response is increasingly attributed directly to the gut composition. So apart from the Rosburgia intestinalis or the Lachnoclostridium veillonella, the microbes written in our text is Faecalibacterium. So Faecalibacterium, presence of Faecalibacterium is actually yes, time is the time over.
Just yes. No, you can just think. I mean, running just a little bit behind the timing, so you can just.
Yeah. I'll
You can continue.
just summarize in 5 minutes.
Sure.
Okay, so the Faecalibacterium is associated with a long progression-free survival rate, and the bacteroids, actually the presence of bacteroids is a bad indicator. It is associated with short progression-free survival rate. So this was another scenario where the patient was a responder in presence of Akkermansia mucinifila, and that caused tumor shrinkage. So these are the other examples where cell cycle specific drugs could be activated by microbiomes because of the reactive oxygen species, or the cyclophosphamide efficacy could be affected by microbiome species. So metformin, we all know that metformin, the oral hypoglycemic action of metformin, uh, it is also attributed to Akkermansia mucifila, as the drug reshapes the gut ecology in encouraging Akkermansia species, and it increases the short chain fatty acid, which drives host insulin sensitivity. So the other drugs that can affect the microbiome include the proton pump inhibitors, which can cause severe Clostridium difficile infection. And apart from Akkermansia mucinifila, metformin enriches the E. coli and the intestine bacteria. And the dietary patterns, the plant-based diet will increase Prevotella, which is cardioprotective, and the ketogenic diet will decrease the bifidobacterium, which reduces the inflammation. So these are examples of various drug metabolism and microbiomes. So you can go through the slides later. We have covered almost all the important ones that have been cited in the textbook. So coming to the conclusion, uh, I'm skipping all this because we have covered. So how can we what can we do for this? One, as Remimam has already told, that is whole ecosystem therapy, that is fecal microbiota transplantation. And as of now, we have Rebiota, which is a single dose rectal enema. And the first oral capsule is the worst fecal microbiota spores. Apart from that, we have targeted prebiotics and probiotics, and also non-antibiotic enzyme inhibitors, as we have already told in the case of L-DOPA decarboxylation. And the designer microbiota, like E. coli engineered to express a phenylalanine hydroxylase, which could be effective for preventing neurological defects, or the phage therapy. So does anyone recognize these persons? Is Stephanie Strathy. She was a psychiatrist as well as an epidemiologist who initiated phage therapy in her husband, who had severe Acinetobacter infection. So that is targeted phage therapy, and they have documented everything in a book called Predator. So I am skipping through this. The Agora 2 is a large genome microbiome resource, and we need to decode the raw metagenomic chaos. We need to reduce the noise of the diet, age, season, lifestyle, these confounders, and concentrate on the mapping of the genetic material, that is metagenomics, transcriptome, tracking changes in the RNA and transcriptome following drug administration, that is metatranscriptomics and metaproteomics. And for the future of precision pharmacology, apart from assessing the host DNA, we need to assess the metagenomics tool sequencing, and then go for the precision. And the baseline profiling, predictive modeling, and the microbiota targeted regimen is going to be the future. And the model informed drug development, along with the host contributions, the microbiome contributions should also be taken care of. And we need to validate with real world data, and the responder and non-responder profiles should be assessed before starting a treatment. And the next era of precision medicine will treat the human and the microbiome as a single indivisible metabolic system. Thank you for your patience and time. Thank you. I'm sorry for exceeding the time.
Um, Thank you, ma'am. It was such an insightful session. It was a very engaging session. You've given a very detailed explanation of the topic. along with all practical examples, real world relevance, and everything. It was very helpful, ma'am. Thank you so much.
Okay,
Um,
thank you.
Thank you, ma'am.
I'll be sharing the slides. Okay,
Okay, ma'am. Thank you so much. If
thank you.
there are any questions, we would connect you back and get the information from the same. Thank you.
Thank you for the opportunity. Thank you.
Thank you.